Bonjour tout le monde, très heureuse de vous retrouver à notre rendez-vous mensuel sur la médecine de précision en psychiatrie. Après deux conférences d'introduction, on va rentrer dans le dur du sujet et vous montrer des exemples précis de ce qu'on peut faire aujourd'hui en médecine de précision en psychiatrie. And today we're really happy to listen to Professor Andy Miller, who is Professor of Psychiatry and Behavioral Science at Emory University School of Medicine in Atlanta. You all know, because you've listened to him last year already, that he's a world specialist in the field of immunopsychiatry, and he's going to show us how immunology can pave the way to precision psychiatry if and only if we learn from past failures in clinical trials. So, Andy, thank you very much to have waken up so early for us this morning. And you're going to give a splendid talk after just a small cup of coffee. So thank you so much.
Thank you so much, Marion. It's really a pleasure to be with y'all today, and I'm very excited about talking to you about the work that we do. And I'm going to be focusing on the effects of inflammation on the brain, which is obviously my area of expertise. But today, my special emphasis is going to be on the mechanisms involved. And the goal here is to develop treatments that target these mechanisms and ultimately develop targeted treatments for specific pathways in specific individuals. And this, in the long run, will support the development of precision psychiatry, whose essence is based on understanding mechanisms, connecting the dots, revealing the pathways that lead to the pathology, and then targeting these pathways. But in order for any of this to happen, the field of psychiatry has got to change. And most importantly, that we need to change the way we think about and the way that we conduct our clinical trials. And as I hope I'll convince you today, the current clinical trial designs that we use in psychiatry are not well suited for the development of targeted treatments. Our current clinical trials are better suited for non-specific therapies that address over-inclusive psychiatric diagnoses, enrolling heterogeneous populations of patients, and using broadly defined outcome variables that are quite non-specific. These trial designs are dinosaurs, and they're vestiges of past successes in psychiatry, and we'll talk about that. So today I'm gonna kind of walk you through my journey in the immunopsychiatry space and talk about how we can embrace the opportunities inherent in understanding the specific mechanisms by which inflammation affects the brain, with the idea that this can serve as a model of how to develop targeted therapies in psychiatry in general and move the field forward to precision psychiatry. But first, we have to acknowledge that there is ongoing a crisis, and the problem, as far as I see it, as I mentioned to or alluded to before, is the clinical trials. And in my world, the trials really involve using anti-inflammatory drugs to treat a variety of psychiatric disorders. And the disorder that I focus on is depression. So there have been a number of trials, somewhere in the range of 50-odd trials that have been conducted with various anti-inflammatory drugs. And there are meta-analyses of this literature, and they suggest that anti-inflammatory drugs may have some modest, and it's quite modest, efficacy in treating depression. However, the results have been underwhelming. You don't see pharma running to try to develop anti-inflammatory drugs at this point for the treatment of any psychiatric disorder, let alone depression. And probably most damning to the field is the fact that the two of the largest recent studies, there's a Hellman-Reagan study et al. In 2022 and a Hussein et al. Study in 2020. Large N's here, using two of the major drugs that have been used in these previous trials, in these meta-analyses, celecoxib, minocycline, both found no separation from placebo. And this just kind of gives you a feel of what this data looks like. So there was a celecoxib group, 50, 60 patients per group, so it's not insignificant sample sizes here: celecoxib, minocycline, the combination, placebo, published in a high-profile journal. And you can see here there's absolutely no difference between these drugs and their combinations with placebo. Now, as you might figure, most people read the abstract, and so you get into the abstract and you get to the final conclusion, and fair enough, there's no evidence that minocycline or celecoxib was superior to placebo. That's obvious. But then they add this little tagline, or a little final thought here, which this large trial casts doubt on the potential therapeutic benefits of adjunctive anti-inflammatory drugs for the management of bipolar depression. And that's a field killer. These are the kinds of conclusions that people say there's no there, and no interest in further pursuing the use of anti-inflammatory drugs in depressive disorders, and obviously jeopardizing for other psychiatric disorders as well. But what I want to point out to you is that these clinical trials, as currently conducted, have failed the field. And what are the failures? Well, the first and foremost is the sample. These studies have included heterogeneous populations of depressed patients by and large, and inflammation only occurs in a subgroup of depressed patients. So why on earth would you consider that you're going to get a positive result if you're studying everybody under the sun and only a small subset of your patient population actually has the pathology of interest? The other issue here is that the primary outcome variables are the standard Hamilton Depression Rating Scale or the Montgomery-Åsberg Depression Rating Scale. These are non-specific measures. You've all looked at these things. They contain any number of different symptoms that really are kind of vaguely related to one another, but really represent fairly specific domains of pathology. And what we know about inflammation is it has very specific effects on the brain and behavior, as I'll show you later. So why would you expect to have this overall effect when inflammation is having very specific effects on the brain? And then finally, the drugs that have been used, we really have not done a good job in determining, well, are they actually hitting the target? Many of these drugs have limited potency. Celecoxib is, something that's not a terribly strong anti-inflammatory drug, for example. These drugs have multiple off-target effects. And there have been few studies that have looked to see, well, did you actually lower inflammation in those patients who had it, either in the blood or in the brain? So there are a number of things that have gone on in these trials that really make it very difficult to make any interpretation of their results, and unfortunately have limited value in terms of the field in general. The problem is that this isn't just about me and my world of immunopsychiatry. This is about psychiatry. This has happened before. We're not alone here. And I'll tell you about the trial fails, and some of you may be familiar with the trial failures of drugs targeting the hypothalamic pituitary adrenal axis. I think most of you know that many of our psychiatric disorders that we treat are stress-related disorders, especially anxiety and depressive disorders. And much research had been done to demonstrate that activation of the HPA axis plays a role in this stress-induced pathology, and corticotropin releasing factor was identified as a key molecule in regulating the stress response, and blocking CRF, corticotropin releasing factor, was shown in animal models to exquisitely reverse, resolve, abolish, abrogate the effects of stress on behavior. So they set about, this was a very exciting time in psychiatry, and the idea was we were going to come up with the first targeted treatment, and in this case, corticotropin releasing factor antagonists. And unfortunately, these drugs, there was a lot of excitement in terms of the drug development process. Many psychiatrists were getting into the whole spinning off little businesses, and a number of compounds were generated. And this is a review of the literature, and it's really about what, trying to figure out what happened here. But look at the results. I mean, these number of compounds were developed and just failed, one after the other, in major depression, anxiety disorders, PTSD, suicide, really no effects whatsoever. And in this particular review, they're sort of trying to figure out, well, what happened here? Is somehow, did we conceptually miss the boat? How did this get lost in translation from to the bench to the bedside? There were even, I talked to colleagues of mine who couldn't get their grants funded because they were convinced that animal models of stress-induced pathologies and behavior were irrelevant, had no bearing on what goes on in humans. But they also recognize something that that is very clear to us in the immunopsychiatry space, is that maybe they should have thought about doing that. Maybe these CRF antagonists are their response is circumscribed in this review to particular psychiatric disorders or symptoms, particular subgroups, or circumstances in which there's actually measurable activation of the HPA axis and the CRF pathways. So again, there was no enrichment of the populations. They did heterogeneous groups of populations. And as I'll show you in a minute, not everybody has problems with the HPA axis in their pathologies. So like before, they made many of the same mistakes that we're making now, and it's like deja vu all over again. Same story with the glucocorticoid antagonist. Some of you may be familiar with this as mifepristone, also used as an abortifacient drug, and does block glucocorticoids and has been used in psychotic depression. However, in the clinical trials that they've done with psychotic depression, which we know is associated with hypercortisolemia, they've not enriched for patients with hypercortisolemia or HPA axis abnormalities in the clinical trials of these drugs. The results have been mixed and no translation to clinical practice to date in the last 20-odd years. And it traces to what I sort of alluded to before, is that not all patients that we see have the same biology, and that there's subgroups of patients with very specific biologies that need to be identified and targeted if we're going to move forward in terms of precision psychiatry. This just gives you an example of this. Of the subgroups here. Here we're looking at concentrations of corticotropin releasing factor in the cerebrospinal fluid, and you can see this is a generous slide. There have been other studies done, and even fewer patients have elevated CRF in the CSF. But this one, it's just under half have increased elevations in CRF. But look at the rest of the patients. They're no different than controls or schizophrenics or patients with dementia, as published in Science by Charlie Nemiroff, who is one of the people who was a big proponent of this hypothesis. And We see the same thing in inflammation. I mean, many times you see the bar graphs, and the bar graphs look different. Great. Look at the individual dots here, and you can see that, in fact, even if you had a bar graph up here, that really it's a subgroup of patients that are exhibiting increased inflammation. And the majority of depressed patients do not have increased inflammation. So why on earth would you give an anti-inflammatory drug to all of these people when these guys aren't going to respond at all, and these may, depending on the efficacy of your drug in blocking inflammation. And here's comparison groups with healthy controls. These are depressed cancer patients, maybe a little higher percentage here. Obviously, numbers are small here, but you get the idea. We published this in almost 25 years ago, and should have figured this out by now, but apparently not. Depression is not an inflammatory disorder. Okay, so I think if there's anything you take away, you just take that one point away. So how did we get here? How did we get to this point where we're treating everybody the same in our clinical trials, and we don't seem to want to change, and we keep searching for drugs that have these non-specific effects across disorders? Psychedelics are a perfect example. They feel so warm and comfy because they feel like antipsychotics and antidepressants that we already have, drugs that work in large swaths of our populations and patients. So I think a lot of this started with serendipity. Most of the drugs, in fact, pretty much all of the drugs that we use in psychiatry today were discovered by serendipity. And I think most of you are familiar with that. Antipsychotics, antidepressants came from antihistamines. The monoamine oxidase inhibitors came from drugs to treat tuberculosis. Mood stabilizers came from anti-epileptics. And these were serendipitous observations that these various drugs that were being developed for other things had broad efficacy in patients with disorders that were grossly defined by consensus at the time. And it's a fascinating story how all these development happened. It just, for example, with the mood disorder patients, they were in the same hospital units with the patients with epilepsy, and they said, oh, well, these patients are running around and out of control. Let's give them some of the drugs that we're giving to the epileptic patients, and they, oh, look, they're responding. And so what that ended up with is that we have a series of medications in psychiatry that are highly nonspecific. We use pretty much everything for everything. I mean, antipsychotics, if you were stranded on a desert island somewhere and you only had one drug, you probably would pick an antipsychotic if you're a psychiatrist because it treats everything. And they actually call antipsychotics antidepressants now, and in the US on TV, and this is an antipsychotic, it's not an antidepressant, but it's being advertised as such. So, and antidepressants we use for everything, same thing with the mood stabilizers, and these are the new kids on the block, and with same thing. And you look at the pharmacology, yeah, we know a good bit about the pharmacology in vitro for these drugs, but we have no idea how they work in humans. And so this is really a non-specificity here of our medications. And I put D2 antagonism here for antipsychotics. There was just a prominent paper published suggesting it may not even be D2 antagonism, maybe D1 antagonism that is the key. But clearly these drugs changed the face of psychiatry. These were huge successes for us, and we kind of had the idea, boy, we've got this made. This is just the beginning. There's going to be the decades of the brain, or however the different agendas that people had, that biological psychiatry was going to take the field by storm, and we have new treatments for everything. And so there are legacies that came from these past successes that have plagued our clinical trial design. And the broad spectrum of activity of these drugs has led to this notion that one size fits all. So in our clinical trials, we see these heterogeneous populations of patients because all the drugs we've had before worked for everybody. So why should we expect anything different? Non-specific outcomes. These drugs are non-specific. They work broadly across a number of symptoms. So our outcome variables are really not aligned with any particular mechanism of pathology related to psychiatry. And of course, then if you have a drug that treats a disorder or treats something, that means it must be a disorder. And so we have very limited appreciation for the idea that there may be these subgroups of patients with specific pathologies that cross diagnoses. And we'll talk more about that relative to inflammation. So basically, we're in a stage very much like oncology where we're doing chemotherapy for the brain. The chemotherapy has an important role in oncology, and these therapies obviously have an important role in the treatment of our patients. In fact, it has this primary role at this point. But clearly, I think we recognize, those of us who see patients recognize that our patients are quite different, even though they carry the same diagnosis. And clearly, one size does not fit all. We have heterogeneous populations of patients within diagnoses, and we want to begin to identify these subgroups and treat them appropriately and treat the pathology that they are expressing. And so that brings us to the inflammation story. And what can we learn about inflammation as a target that can inform a new generation of clinical trials, clinical trial designs and approaches to develop targeted treatments in psychiatry? So first and foremost, I think most of you, if you saw my presentation last year, if you haven't been living under a rock, you pretty much know that there's a lot of data to suggest that there's a link between inflammation and depression. And it includes a large body of data from a number of different areas. One of them, first and foremost, patients with depression exhibit all the cardinal features of an inflammatory response with increases in inflammatory cytokines, interleukin-6, tumor necrosis factor have been the most reliably elevated, and meta-analyses of this literature, the hundreds of papers, probably closer to thousands of papers at this point. Also, increases in acute phase reactants that are produced by the liver, C-reactive protein being the most reliably elevated in this regard, and increases in chemokines, cellular adhesion molecules. You can go in the brain, post-mortem brain samples, and see evidence of activation of inflammatory signaling pathways in brain parenchyma, evidence of immune cell trafficking to the brain, and activation of immune cells of the brain, the microglia. And interestingly enough, something that plagues us in psychiatry, these patients that don't respond to conventional treatments, there appears to be a special relationship between increases in inflammatory markers and treatment non-response. And this is especially the case for conventional antidepressants, the SSRIs and the SNRIs. And this is just some data from a study we did several years ago, just under 100 unmedicated depressed individuals. And we asked them, in your current episode of depression, how many treatment trials have you failed? And as you can imagine, most of the people hadn't been treated at all. But of those who had been treated and failed 1, 2, or 3 or more times, you see this stepwise increase in TNF, stepwise increase in IL-6, same thing with a soluble receptor for TNF. See a similar pattern with CRP, and this was the trend here was significant. But we didn't see differences between the groups here, although the UK group has shown that treatment-resistant depressed patients have significantly higher CRP than treatment-responsive depressed patients or normal controls, and we did not include that in this particular study. Addressing the cause and effect relationship between inflammation and depression are data showing that you can administer inflammatory cytokines, interferon alpha or other inflammatory stimuli, typhoid vaccination, endotoxin typically given to healthy volunteers. And in these non-depressed patients, you can cause them to develop depressive symptoms. And we've learned a lot about the neurotransmitter systems and the neurocircuits that are involved based on these studies. You can also inhibit inflammation, and that will reduce depressive symptoms. And this has been most convincingly demonstrated in autoimmune and inflammatory disorders where the patients are getting anti-cytokine therapies, and this is shown in meta-analyses of these data that these anti-inflammatory treatments will reduce depressive symptoms, treat depressive disorders in these populations. But then the question is, what about otherwise healthy psychiatric patients? And clearly the jury is still out, largely because of these clinical trials issues that I mentioned previously. So there's a lot of data here to say, hey, the depression and inflammation are linked. But as I said before, I'll keep showing this slide until people get it. The depression is not an inflammatory disorder. It really only occurs in about 30% of patients, and it's not all about depression. You see increases in inflammation in association with behavioral changes, not only in mood disorders, but also anxiety disorders, schizophrenia, neurodegenerative disease, medical illnesses, all where you see increases in inflammation in association with prototypical behavioral responses. And so how we understand the field is that this is truly a transdiagnostic phenomena. Inflammation's effects on behavior are really not about any specific disorder. If there is significant increases in inflammation, that's going to affect specific neurotransmitter systems in the brain, specific neurocircuits, and lead to specific symptoms. And this occurs across disorders. So what about the effects of inflammation? What about these mechanisms? What do we understand about these mechanisms? And the point here is we understand a ton. This is based on studies from in vitro work, animal laboratory animal studies, studies in humans. What we know is that inflammation affects monoamine metabolism, reducing the synthesis and release of monoamines, increasing the reuptake, so reducing monoamine availability, which we all know is related in part to the monoamine hypothesis of depression. Effects of inflammation on astrocytes affect glutamate metabolism, such that astrocytes increase their release, decrease their reuptake of glutamate. Glutamate builds up into the synapse. There's extrasynaptic spillover of glutamate, which binds then to extrasynaptic glutamate receptors, which are excitotoxic. And these extrasynaptic glutamate can also bind to adjacent neurons, leading to chaotic, imprecise signaling and disrupt functional connectivity amongst brain regions. And then these cytokines can affect growth factors, neurogenesis, ultimately affecting neuroplasticity. And these effects on neurotransmitter metabolism and neuroplasticity ultimately affect neurocircuits in the brain. And if you look at the data and sort of pull it all together of studies looking at giving individuals exogenous inflammatory stimuli and doing neuroimaging studies, or looking at individuals with high levels of endogenous inflammation and looking at neuroimaging studies, what you see is that there are two circuits that are primarily engaged by inflammation. One involving anxiety, arousal, and alarm, which includes the dorsal anterior cingulate cortex, insula, hippocampus, and amygdala, and then the effects of inflammation on subcortical circuits in the brain, including the basal ganglia and its connectivity with the ventromedial prefrontal cortex, the subgenual anterior cingulate cortex, and also motor regions of the brain. And these effects on subcortical regions that are involved in motivation and reward processing lead to a loss of interest and pleasure, loss of motivation. And as many of you know, anhedonia is a core and probably the most disabling symptom of depression, and inflammation reliably leads to anhedonia through effects on these circuits and these pathways. And much of the work that we have done in our laboratory has focused on these effects on subcortical circuits and their relationship to anhedonia. But I should just mention the work by Lucille Caperon, who's in Bordeaux, was a postdoc and a faculty member with us at Emory, was actually the first person to describe the effects of inflammation on dorsal anterior cingulate pathways and these circuits here, leading to anxiety, arousal, and alarm. But I'm going to focus the rest of my presentation on the mechanisms related to subcortical circuits. So in order to study the effects of inflammation on these subcortical circuits in the brain, we studied patients who were receiving interferon alpha. This is one of the early immunotherapies in cancer treatment, also used to treat infectious diseases. And interferon alpha was noted quite surprisingly for people to lead to depressive-like syndromes in 30 to 50% of patients, depending on the dose. And the syndromes that they presented were predominantly neurovegetative in nature with a lot of anhedonia. So we immediately went to determine whether or not the circuits involved in motivation were affected by interferon alpha. And in order to study this, and the particular area that we focused on is the area called the ventral striatum. This involves the nucleus accumbens and the tag of the caudate and the putamen right in here. And to activate this brain region, we used a motivational reward task, a gambling task, and then functional magnetic resonance imaging. Patients got into the scanner. They saw two cards face down. They were asked to pick a card. If they picked a red card, they won $1. They picked a black card, they lost $1. We rigged the game. Everybody won. They got paid to be in the scanner. If you look at the win versus lose contrast, you see beautiful activation of this ventral striatal brain region here. And this is in the sample as a whole. However, if you split people out into those who are receiving interferon alpha versus control individuals, these people were actually receiving interferon alpha for hepatitis C, and these were hepatitis C patients awaiting interferon alpha therapy. The control individuals, 4 weeks of interferon alpha, and you see that those, the red dots, the interferon alpha patients are showing significantly reduced ventral striatal activation during this reward task using fMRI, and this is the work of Lucille Caperon, who is, as I mentioned, is in Bordeaux. And these changes that we see in ventral striatum, always important. If something's happening in the brain, you want to see it happen in behavior because that's what we deal with. The lower the activation in this task in the ventral striatum, the higher the level of reduced motivation or anhedonia. So you can see this is a nice, strong relationship in the sample as a whole, but you see a clustering of these red dots here is showing both low activation and high levels of reduced motivation. So inflammation, chronic exposure to an inflammatory cytokine leads to reduces in ventral striatal activation that's associated with reduced motivation. Now, this isn't just about interferon alpha. It's one of the things that's extremely important in science in general is reproducibility. Yeah, you got these results, but can anybody else get them? And the answer is absolutely yes in this situation. So similar results have been found with endotoxin as well as typhoid vaccination. So three different inflammatory stimuli studied in 3 different laboratories have all shown decreased ventral striatal activation in response to a reward stimulus on a task-based functional magnetic resonance imaging, and that maps onto depressive symptoms, including anhedonia in these studies. This is an extremely reliable effect of inflammation on the brain. So what might be mediating this at a neurotransmitter level? And I think most of you are aware that motivational pathways, dopamine plays an extremely important role. So we wanted to look at dopamine in the ventral striatum as a function of exposure to an inflammatory stimulus. And in order to do this, we had to develop an animal model of cytokine-induced depression. And this animal model was developed by Jennifer Felger, involved rhesus monkeys, and we treated the animals with interferon alpha, which leads to a depressive-like phenotype in these animals, much like in humans. And then we did in vivo microdialysis, where we put a probe in the brain just north of this ventral striatal region. And these probes can both sample extracellular fluid as well as put in drugs that can stimulate dopamine release. And what we found at 4 weeks of interferon alpha led to marked reductions in dopamine in this striatal brain region, where we saw the decreases in activation in the humans that mapped onto the anhedonia. You see significant decreases in the major metabolite of dopamine, homovanillic acid. And then if you go in to stimulate dopamine in these animals with either potassium or amphetamine, you can see that there's a marked decrease in stimulated dopamine release in these animals. And this decrease in stimulated dopamine release was associated with decreased effort-based motivation in these animals. Reproducibility. This has also been shown in rodents. So you can give interleukin-6, for example, to rodents intraperitoneally. You can do in vivo microdialysis again in the nucleus accumbens, which is part of that ventral striatum. This is in rats, the work of John Salomon at the University of Connecticut. And here he's putting his probe. These are different locations of the probe in the nucleus accumbens. And what you see, it just really doesn't matter where he puts the probe. In each case, after administration of interleukin-6, you see significant reductions in extracellular dopamine, and that decrease in extracellular dopamine was associated with reduced motivation. So you see this convergence of data showing that if you expose animals, humans, to inflammatory stimuli, it leads to decreased dopamine. We've also shown this in humans using fluorinated L-DOPA in humans. Same thing, decreased release of dopamine. So you see this decreased release of dopamine in the ventral striatum. You see decreased activation of the ventral striatum. And this is all associated with decreased motivation in these various paradigms. Now, this can be reversed, so that's important here. We want to do some therapy here at some point. And so Jennifer Felger, who was doing this work in the laboratory animals, put in L-DOPA in the brain. There was some data to suggest that maybe synthetic pathways for dopamine were being affected by inflammation. So she jumped over all the synthetic pathways and put the immediate precursor to dopamine into the brain and was able to completely reverse the effects of interferon alpha on stimulated dopamine release in the striatum in the rhesus animals. So this is something that can be reversed. So what about everything I've shown you up to this point is exogenous administration of inflammatory stimuli, and what does it do to the brain and ultimately behavior? What about endogenous increases in inflammation? How do they affect motivation and these circuits that also involve motor circuitry? And in order to study this, we've moved to resting state functional connectivity and asked the question, does endogenous inflammation disrupt connectivity in these motivation and motor circuits? And we were focused on depression. And I think most of you are aware of resting state functional connectivity. Patients get in the scanner, they stare at a cross. And what we're looking at is the relative synchronous activation of different brain regions, and those that are activating in synchronous fashion, we believe are talking to one another, and these can then form circuits, and then we map those circuits onto behavior. And the particular circuits that we were interested in were these that involve the ventral striatum. And this ventral striatum connects to ventromedial prefrontal cortex. And in red here is the heart of your reward circuitry. And in these more dorsal regions of the striatum, the caudate, putamen that we looked at before, these connect to more motor regions. And so here you're really covering both motivation and motor activity, which is what these subcortical nuclei do. And what we wanted to know is, how does inflammation impact these circuits in the brain in patients with depression? And in order to index inflammation, we had to have a marker of endogenous inflammation. So we used C-reactive protein. And we really like C-reactive protein. In the United States, it's run under standard conditions in certified laboratories. So it is a clinical test where people can go out and get their inflammation levels. We can do this in patient populations. And thanks to the American Heart Association, the Centers for Disease Control and Prevention, we know what is a low, medium, and high level of inflammation. And interesting, if you look at a plasma CRP, these are depressed patients. Those with high levels of CRP have very high levels of these other markers of inflammation, IL-6, TNF, IL-1. And if you do a composite measure of these, you see that this is being captured by this high level of CRP here in the plasma. And here are the individual markers. You can see they're pretty much elevated across the board in those with a high CRP. This also applies to the cerebrospinal fluid. So if you go into the brain and you measure these same composite markers, or these same individual markers of inflammation, you can see that if you have a high plasma CRP, you also have a high composite marker of inflammatory mediators in the brain. So the CRP over 3 is a very nice marker of both plasma as well as central levels of inflammation. And so what we wanted to know is, as your inflammation goes up, as indexed by CRP, what happens to the connectivity between the ventral striatum and other brain regions? And so what we found, and here we put the seed here in the ventral striatum and look to see its connectivity to all other brain regions, and which brain region was changing, the connectivity between which brain regions was changing the most as a function of increasing CRP. And the brain region that we noticed was the ventromedial prefrontal cortex, right? And that reward circuitry, and the effect that we saw was negative. So basically, as inflammation goes up, your reward circuitry is tanking. And here it is graphed. This CRP goes up. This is the connectivity between ventral striatum and ventromedial prefrontal cortex. And you can see that connectivity is going down as a function of increased CRP. And this decrease in connectivity that we saw was associated with increased anhedonia in these patients. And if you looked at more dorsal regions, you also saw decreased connectivity to more motor regions of the cortex, and that was associated with motor slowing. So again, we're seeing the same patterns that we're seeing with endogenous inflammation as we saw with exogenous inflammation. This also can be reversed. So we did a pharmacologic fMRI. So we do a scan, do a resting state scan with the patients, give them a dose of levodopa, and then scan them again, all done in the same day, and look at this connectivity between ventral striatum and ventromedial prefrontal cortex. You can see under baseline conditions, those with high CRP have decreased connectivity. And look what happens when you give them levodopa. Not much happens at all in the individuals with a lower CRP. Those with high CRP show a nice increase in connectivity, and that increase in connectivity was associated with reduced anhedonia in these patients and increased psychomotor speed. And this is, and it suggests maybe there might be some supersensitivity. I just make a point here. If you're going to use CRP as a biomarker for a treatment, you have to show that patients with high CRP, patients with low CRP don't respond to the drug, and those with high CRP do. That is a requirement of the regulatory agencies if you use a biomarker, something to keep in mind. So we've identified some targets here. We've identified dopamine as a potential target. We've targeted symptoms of circuits related to motivation and motor activity. We've identified symptoms related to anhedonia, fatigue, and psychomotor slowing. And we have a biomarker where we can begin to identify patients. So we're sort of building a case for what can be done in terms of clinical trials in this space. And patients with increased inflammation may preferentially respond to dopaminergic drugs. So it's a good start. And we are conducting clinical trials with bupropion as well as levodopa, but there are another number of other dopaminergic agents that could be looked at in targeting the effects of inflammation on the brain. I'm going to skip over this here and talk about what can we learn in terms of clinical trial design in the studies that have blocked inflammation. And I'm going to focus on the studies that we've done at Emory. And many of the studies that we have done involve using the monoclonal antibody infliximab to TNF. And we like these. These are biologic drugs. They're very potent. They have limited off-target effects and limited drug-drug interactions. And so we were one of the early groups, first group actually, to do a randomized controlled trial using a monoclonal antibody to TNF for treatment-resistant depression. This just gives you the design of the trial, 30 patients per group. We stratified people by sex and CRP, 3 infusions that they got, and then we measured the Hamilton Depression Scale over 12 weeks of treatment. I should just mention that these patients had very high levels of CRP. We recruited them based on treatment resistance, and the patients who walked in the door had quite high CRP, and in fact, almost 50% of them had a CRP greater than 3. So if you actually do the math of the number of people who are depressed, I'm just refer to the US here, and the number of individuals who are treatment resistant and the number of those who would have high inflammation, you've got 5 million people in the United States who are have treatment resistant depression and increased inflammation. You can compare that to people with rheumatoid arthritis and inflammatory bowel disease. So we were quite excited about this study when we did it, and this is what we found. And this should look very familiar to the graph I showed you at the very beginning of my talk. And like everybody else, we figured that depression was an inflammatory disorder, that giving them a potent anti-inflammatory drug should work for everybody. But eventually we kind of figured out, well, maybe we should ask the question, does it matter whether or not you have inflammation as to whether or not you respond to the drug? And the answer was absolutely. So the higher the CRP, the more likely you were going to respond to treatment over time. The sweet spot was a CRP greater than 5 in this study, and it represented about a third of our sample, and you can see a doubling of response infliximab versus placebo in this population. And look at the individuals with lower levels of inflammation. They're actually doing worse than on infliximab, suggesting that giving anti-inflammatories to just a random group of depressed patients may not be a great idea if you're not parsing out those who have high inflammation. What are the symptoms that responded? So here are the 17 items of the Hamilton Depression Rating Scale. This is in the group with CRP greater than 5 who showed the response. Here we're at baseline, and if we're going in this direction here, a negative score here means your symptoms are getting better. And look at the symptoms that really are differentiating the patients who are responding, the patients who are getting, who had high CRP versus the placebo. And you can see the symptoms that are getting better are the work and activities item. That's the anhedonia item on the Hamilton, psychomotor retardation, and then anxiety, that circuit that I showed you in the beginning. So this maps on very nicely what we know, and again, addressing the issue of reproducibility. There have been a couple of other studies using cytokine antagonists in depressed patients, work by Roger McIntyre, who also found that the major symptom that moved in patients given anti-cytokine treatment with depression was anhedonia. And the Janssen sirukumab trial with anti-IL-6 also found, they haven't published yet, we're waiting for them to finally publish that, found that anhedonia was the most responsive symptom. None of the studies were able to hit the HAM-D. And even the Janssen trial, they did not hit the HAM-D except in patients who had very high inflammation. So we know a lot about how inflammation affects the brain, and this should form the basis of intelligent clinical design in this space. We know about immune activation. We know that it has effects on neurotransmitter metabolism, dopamine. I didn't talk much about glutamate, but also glutamate. We know the neurocircuits that are involved, the subcortical circuits, and that those involved in threat sensitivity, in the anxiety realm, and then these lead to behavioral changes that are prototypical of the effects of inflammation on the brain. So where do we go from here? Well, I think based on this information, we can begin to think of strategies for creating a regulatory space for developing targeted treatments focusing on the immune system in psychiatry. So this is how we get to precision psychiatry, is we got to go through all of that business of figuring out what's going on first and then designing the trials to ultimately facilitate the development of the targeted treatments. So first is to enrich. We need to enrich for biological, clinical, or neuroimaging markers that are associated with inflammation. Get those patients who are the patients that we should be targeting into the trials and focus on them in terms of the treatment with anti-inflammatory drugs. So you could use a CRP, anhedonia, obviously a symptom that's common. And these two is actually what we're using in our clinical trials now. But there are other things that one could use to enrich. Challenge here is the regulatory agencies are going to want you to really establish the reliability and validity of these biomarkers. And that's not trivial. And that's why you don't see the pharma running in to do biomarkers for their drug development portfolios. It just what the FDA and what the EMA require in terms of establishing a biomarker is not trivial. The advantage is if you get the right patient population, you might be able to get away with one of these kind of standard outcome variables like a HAM-D or a Montgomery-Åsberg depression scale, which is what the FDA wants you to use. The other thing you could do is you could develop some novel clinical outcome assessments. So rather than doing a Hamilton, maybe you could use scales that capture the thing that inflammation does to the brain. So if you know about the mechanisms and you know what behaviors are affected, you can do scales of anhedonia. That should be your endpoint, right? Makes perfect sense. Believe it or not, the FDA is not approve scales for anhedonia. There's no approved scale for anhedonia. There's a number of other drugs that are in this boat that are hitting anhedonia and are not hitting the HAM-D. The HAM-D is a very crude measure of global mental health, and some of these newer treatments that are targeting symptoms, and you all have patients that continue to have anhedonia, they continue to have fatigue, they continue to have some of these symptoms, even though they're getting the chemotherapy. They need a targeted treatment to improve the disease, which is how oncology does this. So to get a scale across the line, nobody wants to do it. It takes a lot of time, has to be validated and approved, and there is none for anhedonia and most of the other symptoms as well. Beauty is if you can get that approved, your primary outcome is aligned with your treatment target. You could go wild and woolly here and establish new diagnostic categories, which I would love to do, have an inflammation-associated behavioral disorder, and then you just measure CRP and they go high inflammation and they got some behavioral problem, you can treat them that way. That obviously would have to be reviewed by all of the field of psychiatry and alternative diagnosis. It would have to be accepted by the regulatory agencies. But then your disorders align with your treatment, so that would be nice. And finally, we just need to make sure that we're establishing target engagement. This is probably most important in early drug development, and measuring changes in inflammation, other relevant biological endpoints in the blood of the brain, CRP, functional connectivity. The challenges that we don't have really good measures of neuroinflammation, and the key immune pathways have not been well defined. But if we know the drug is hitting the target, then we can interpret the results much better than we have up to this point. So in summary, the time is right, but using what we know, we can use intelligent design, enrich the populations, align the targets and outcomes with what we know inflammation does to the brain, and we can lead the charge in precision medicine and psychiatry. And I think this is, based on the fact that people continue to do the same thing over and over again with these trials, with the non-specific outcome variables, the heterogeneous populations, the failed results, at least in my immunopsychiatry space, where that field is going to be lost, just like the HPA axis field. HPA is done. Nobody's interested. Won't go back to it. And there's probably something there. So there's a certain fierce urgency of now for us in psychiatry to do something different, to start doing targeted treatments, to stop running after these, non-specific therapies that treat everything. And from Martin Luther King Jr., I just grabbed this notion that life's most persistent and urgent question is, what are we doing for others? And right now, we're doing a little bit, but we could do a lot more from what we know about basic neuroscience and clinical science. Let me just acknowledge all the people that were involved in this work, as well as the funding agencies, and I thank all of you for your time. And I'll stop there, and I don't know that we have any time for questions, maybe a minute or two.
Thank you very much indeed, Andy, for this extensive presentation from past to the future. And I hope we all share that the future is bright in front of us. We don't have lots of time, I agree. We have one question written by Bruno Awizerat from Bordeaux, I think about ketamine. I can open it. Yeah. So Bruno is asking you, Andy, what do you think about ketamine? Ketamine blocks NMDA receptors and had potent dopaminergic effects. Bruno, do you want to explain it quickly?
I mean, I can just, yeah.
Yeah, because hello, Andy. In fact, what do you think about ketamine? Because ketamine blocks NMDA receptors, has potent dopaminergic effect, which are able to counteract the negative deleterious impact of inflammation on the brain, glutamate, and dopaminergic system. And ketamine has also anti-inflammatory properties while reducing pro-inflammatory cytokines, especially in treatment-resistant depressed patients.
Yeah, I'm not a big fan of ketamine. I think it falls into the category of the psychedelics. This ketamine, if you look at the list of things that it does in the body and the brain, it's a laundry list of different targets. I'm sure you're familiar with Alan Schatzberg and all the stuff coming from Stanford, where they're using naloxone and blocking the effects, and then the studies where they did the anesthesia, and people who thought they got ketamine got better, and the people who didn't. I mean, it's so complicated, and we're not targeting a mechanism there. And that's where I really think we need to focus on identifying mechanisms of pathology, targeting those mechanisms. It's a completely new thing for us in psychiatry. I mean, look, in the United States, we get bombarded with these antipsychotics that they're pushing as antidepressants, or as mood stabilizers, or as this, or as that. It's our world. And then what do you read about in the newspaper? Psychedelics. We have no clue. And there's a big battle. Well, is it about a psychotherapeutic response? Is it about, that you're going gonzos on neurogenesis and neuroplasticity, and can you disentangle those two things? It's a mess. And then people say, oh, well, we'll reverse engineer it. Well, we haven't figured out how to reverse engineer all the drugs we've been using. I don't think anything's going to change in that department. So I think it's really pushing ourselves to start to think about specific patient populations with specific symptom domains, with specific biologies that we target. I would have no problem if you said, well, what about TMS? What about deep brain stimulation? There, you're kind of targeting circuits in the brain. So at least there's some specificity there. And you say, well, this circuit is associated with, some symptom, and I'm going to target that circuit because this person has that symptom, and that circuit is related to that symptom. So I think, yes, in that case, you're doing targeted treatments, and that's probably more ready for prime time than what we're doing on a cellular level. But those circuits come from somewhere, despite what the circuit people will tell you. They don't want to talk about biology, but there's a biology behind all those circuit changes that we see in the brain, and that biology can be targeted, yes.
And I fully agree with your approach you propose. I fully agree with you, Andy. Many thanks.
Anybody willing to ask a question? We have a few minutes left.
Willing to ask.
Wishing, willing. No, they're all silent. There is a question about digital tools, but this is going to be addressed next month.
Potential failures of the use of, I got one here in the chat. Failures of the use of current inflammation, potential failures of the use of like CRP. What are your thoughts on the potential failures, the current, and also the potential that inflammation is the consequence and not the cause of depression? Clearly, I think most of us are of the opinion that inflammation, having depression, leads to lifestyle changes, that facilitate inflammation, poor lifestyle habits, dietary issues, lack of exercise, and such like that. And right now, many of the things that you can do for your patients is to emphasize lifestyle changes that are focused on diet and physical activity. But the data that we have, and it's not trivial, suggests that inflammation comes first, depression comes second. So the longitudinal studies have been done. So we know that, yes, there are studies that suggest that if you have depression, maybe you'll have inflammation later on. But the more substantial data is that early inflammation is associated with later depression. In terms of failures of CRP, I'm not really sure what failures of CRP might mean. I think it's interesting what's going on in the cardiovascular literature. The cardiologists are now starting to get CRPs on a regular basis because they just got FDA approval for colchicine, which is a gout drug that is anti-inflammatory. And they found that it significantly reduced likelihood of people having strokes and a second MI. So it is now FDA approved for the prevention of subsequent MI and cardiovascular complications after a first MI. And everyone asked the question, well, why didn't they go in and do it based on a CRP? And it's for the reason that I explained to you before. The problem with a biomarker, if you're going to use a biomarker like CRP, you have to show that your drug works in the patients with the high CRP and doesn't work in the people with a low CRP. That's what is required. So you have to do double the work to get your drug approved. And so they did not do that with the cardiovascular. But if you talk to cardiologists, I don't know that it's 50-50. I think it's probably more 70-30. 70% of those cardiologists are going to say, I'm getting a CRP first before I put somebody on colchicine. So in practice, what they do is they're looking at those inflammatory biomarkers and then giving an anti-inflammatory. But they were, and if you look at cardiovascular disease, the majority of patients do have increased inflammation. So they kind of were already enriched. So they didn't have to go through that biomarker process. But I do think CRP is a viable biomarker to use in clinical trials in the immunopsychiatry space. And it's what we use. We've demonstrated clearly that people with high CRP respond to L-DOPA and those with low do not in terms of what changes in the brain. So I'm in my clinical practice, do I get a CRP? People ask that question and I say, yes, absolutely. And then I might to adding a dopaminergic agent, whether it be some type of a bupropion, a stimulant, a pramipexole, and in some patients, levodopa. But, we all deal with patients that don't respond and have persisting, especially the kind of negative symptoms that we see, the apathy, poor motivation, fatigue, these kinds of symptoms. And this is the space that I think is a very open space for immunopsychiatry and the effects of inflammation in certain patient populations. And this also goes for chronic fatigue, long COVID. I mean, there are all these inflammatory conditions where patients, these kinds of treatments may be relevant. Lyme disease as well.
Well, thank you very, very much indeed, Andy, for sharing your vision and thoughts and hope with us. I'm sure everybody is aligned now with the vision we have about the hope coming from immunopsychiatry. We would probably have hundreds of questions. We're looking forward to seeing you in Brussels mid-May to continue the discussion in precision psychiatry with lots of important people in the field. And thank you very much for having waked up so early this morning. So thank you very, very much. And goodbye.
Thank you. I really appreciate it. Just nice to see y'all again.
Thank you.
Thank you, Andy.
All
Thanks a
right.
lot. See you
Yeah.
soon.
Okay.
Thanks, y'all.
Bye-bye.
Bye.